Hi, I'm Megan Flanagan. I think I recognize everyone for the most part on the list here that I'm seeing, and I'm one of the breast surgeons. I'm going to be sharing the stage here with Dr. Gillespie. We're going to be talking about some of the local regional therapy updates from San Antonio. And I apologize, my slides are from when I gave this talk at the Washington State Medical Oncology meeting, but they're all still relevant. Something weird's coming up. Okay. Continue to share. Can you guys all see my screen?
Yes, looks good.
Okay, great. Thank you. Okay, so I'm going to talk about COMET and SEMA and Alliance. We've kind of already in our faculty meeting, what was it, a month or two ago, talked about in SEMA, but never hurts to talk about it more. And the Alliance trial data is not outcomes data, unfortunately. Again, similar to last year at San Antonio and similar to many of the surgical meetings, the question is kind of like on one of de-escalation. So can we do less surgery but still have reasonable outcomes? So I think many of you have heard about the COMET trial. This is the 2-year data randomized controlled trial on active monitoring with or without endocrine therapy versus standard of care for low risk DCIS. So this is the general schema of the study. It started enrolling several years ago. This is the pre-planned 2-year analysis. And I have some other slides that go more through the eligibility criteria because I think this is, as we discussed all of these studies like in SEMA and SOUND, and actually even the Alliance criteria to think about who actually was enrolled in the study. So women over the age of 40 who had screen detected low or intermediate grade estrogen receptor positive DCIS, so not high grade, not ER negative, could be unilateral or bilateral if they had more than 4 centimeters of disease, meaning essentially all of these patients had calcifications. They needed to have a second biopsy. Stratification factors were age of diagnosis, extensive calcifications, and nuclear grade. Hey, Nancy. Oh, great. Thank you. So the 2 arms of the study were guideline concordant care, which you can see here is, the plan was for surgery at diagnosis within the first 6 months. This was lumpectomy or mastectomy based on patient preference and extent of disease, although most of these patients had very small volume disease for obvious reasons. And adjuvant radiation was per radiation oncology recommendation, and fields and other things were not specified. Adjuvant endocrine therapy was permitted. The active monitoring group underwent ipsilateral mammogram Q6 months and an annual for the opposite, the contralateral breast. If they had imaging changes, extensive calcifications, development of a mass, they had to undergo biopsy. And if they were diagnosed with invasive cancer on any of those subsequent biopsies, they were supposed to undergo surgery. Again, also in this group, adjuvant endocrine therapy was permitted. So the primary outcome of the study was, this was pre-planned to have this 2-year ipsilateral invasive cancer diagnosis. I think this was more of a safety endpoint just to make sure that as we're doing active monitoring in this patient population, we're not, finding high rates of invasive cancer occurrence, which is a good safety endpoint, but not a great long-term outcome endpoint because 2 years in low-grade DCIS, as we all know, is, we don't expect high rates of invasive cancer necessarily to come up. Secondary outcomes were 2-year rates of mastectomy, radiation, chemotherapy, and some patient-reported outcomes. They do have pre-planned 5, 7, and 10-year outcomes analysis that they will be reporting out on. So there were 995 patients enrolled and randomized. You can see half and half, active monitoring, guideline concordant care. I tried to highlight the things that are, I think, the most significant take-home point for this study. Most of the patients started the study, but you can see in the active monitoring arm, 88% adhered to their randomization arm. So they were assigned active monitoring and they did active monitoring. When we look over here at this guideline concordant care group, only 52% adherence to randomization. So basically about half of the patients who were randomized to get surgery were like, I'm just going to do active monitoring. So right away, a little bit of a red flag because, the and ultimately they did a per protocol analysis because they sort of expected that there would be some crossover in terms of patients not allocating to their randomization scheme, but this was very unexpected, and it brings up a couple of points which we'll talk about later, which is like, who are these patients? Do they represent the majority of patients that we see? I would argue probably not. And how can we generalize this to most of the patients that we see in terms of compliance with imaging and things like that? So they did two analyses. The intention to treat population, again, half the patients in the guideline concordant arm here did not get surgery. You can see actually a pretty good distribution of patients in terms of age, race, and DCIS grade. The majority actually were intermediate grade. And then when they looked at the primary outcome, which was invasive cancers at 2 years, there were, a slight difference in size, but again, under 1 centimeter in size for the invasive cancers that developed. And if you look at these numbers, seems like high rates of nodal positivity, but this is actually in the grand scheme of all of the patients, extremely low numbers, less than 1% in the guideline concordant care group. And the distribution of the invasive cancer grades, a very small proportion of patients who ultimately had high grade cancers. So this is the intention to treat primary endpoint. You can see here, guideline concordant care right in the blue. The ipsilateral invasive cancer rate went up very quickly for those who actually underwent surgery because they had surgery, and then sort of stabilized off with not many people ultimately developing cancer if they didn't undergo surgery. And then the active monitoring here just sort of slowly increased over time. The delta for these two groups was 1.7%. And I'm sorry, I didn't say previously that this was a non-inferiority study, and the difference was estimated to be about 5%. So this was considered non-inferior because it was less than 5% difference. If we look at the per protocol analysis, is that right? Yeah. If we look at the per protocol analysis, we follow this yellow line here. This is the active monitoring. Of course, no one got diagnosed essentially before 6 months because that was their first imaging. They would have had to have developed like a palpable mass in that standpoint, which low to intermediate grade DCIS really wouldn't be expected to do. And then you can see just over time, people are developing changes with their imaging, and they're developing cancers that then need surgery. Again, here, per protocol, most of the people that were on protocol got surgery very quickly, and then essentially no people beyond that developed cancer. If you look at the 2-year cumulative rate in this per protocol analysis, the delta is actually significantly in favor of the active monitoring group, and so they were very careful to say, again, non-inferior, but actually this looks better than guideline concordant care. So I think ultimately they met their non-inferiority goals. It was a 2-year pre-specified analysis. The active monitoring group ultimately developed invasive cancer in 4.2%. There were really no significant differences in the randomized groups between ultimately in the two groups between invasive tumor size, nodal status, or tumor grade. Overall, 31% of participants did not adhere to their arm allocation. But again, in that guideline concordant care group, like almost half didn't. And then their conclusions were that women with low risk DCIS, this intermediate to low grade DCIS, randomized to active monitoring had a non-inferior rate of invasive cancer in the ipsilateral breast compared to those randomized to guideline concordant care. And then they were, of course, careful to say this is short-term results and they need follow-up. So patient-reported outcomes, they looked at a lot of different survey measures, SF-36 for quality of life, state trait anxiety inventory, kind of trying to assess, are these patients, the patients undergoing active monitoring, do they have higher levels of anxiety because they're not having surgical intervention? And then they looked at pain symptoms and other symptoms associated with endocrine therapy. So I We'll also note here that in the active monitoring group, 70% of patients had endocrine therapy. And in the guideline concordant care group, 66% of patients had endocrine therapy. So again, significantly higher than what I would say our uptake of endocrine therapy seems to be in these patients, in the patients that we see, and certainly could contribute to some of the lower risk, the lower rate of invasive cancer occurrence. You can see here the guideline concordant care. None of these are statistically significantly different, guideline concordant care versus active monitoring, although in most of them, the guideline concordant care looks like trends slightly worse for them, but nothing statistically significant. So this is the SF36, just looking at general health. This was actually very similar to normal population norms. This is looking at specific parts of the SF36 mental component score and physical component score. Again, in the physical component, like really no difference here. And although trending towards worse for the guideline concordant care, this was not statistically significantly different in the mental component score. Physical functioning, there was a difference here in timing with the active monitoring looking worse for a short period of time, but then it sort of evened out. So I'm not really sure what to make about that. Anxiety and depression, and this scale worse is going north, higher scores. Again, not statistically significant in terms of anxiety and depression scores. In terms of looking at the PROs, there were really no difference between the two randomized groups. And the takeaway I think they thought with this was that patients who opt for who are randomized to active monitoring or guideline concordant care, they seem to have not as big of an impact on the lived experience of these patients in short-term follow-up. So when I looked at, sort of when I was thinking about this data, first of all, 2-year follow-up data is really not long enough for this patient population. There are other trials that are out there which are slightly different from this study, but we are awaiting data from Lord, Loris, and Loretta. I believe Loris actually closed early because of accrual problems. We need longer follow-up. This really, I think, encourages us to think about patient preferences. Aside from the safety data, which I'm not, convinced about necessarily at 2 years, it does show that PRO outcomes are not necessarily super different, and that the women who maybe are sort of randomized to active monitoring, or those who are randomized to guideline concordant care and then chose active monitoring, maybe for them, they don't have these high level of anxiety that I think personally I feel often that our patients have about keeping the cancer in situ, literally and figuratively. From a healthcare standpoint, these patients have to get Q6 month imaging. So these patients are in a randomized controlled trial, and there wasn't a substantial amount of loss to follow up in this group, although there was some. But we'd have to get them in every 6 months for ipsilateral imaging, maybe presumably forever. If there's changes, they need extra biopsies. So, cost considerations, timing considerations, follow-up considerations, all of these have to be taken into consideration. And then, what was the role of endocrine therapy in this active monitoring group? 70% of patients actually did endocrine therapy, which is a lot. So, what's the trail off of that going to be more long-term? Is this something we have patients take forever? I think there's a lot of unanswered questions with this, but it is promising that at least in the short term, maybe there's a safer route for patients who really don't desire to have surgery. I think in the future, and I know there is work ongoing sort of in our group about thinking about DCIS and imaging results and how do we incorporate other data into figuring out who are the patients who are going to upgrade or have progression, thinking about specific imaging features or genomic testing in these patients. So again, take-home points, interest in active surveillance, but we need longer-term follow-up. And then the active monitoring group needs to be prepared for additional imaging and biopsies. Anyone have any comments or thoughts on that? Happy to do them at the end too, but sometimes it's kind of nice to do it while we're thinking about it. I'll continue on.
I think, Megan, I think the thing that we're all scared about is, the patient who you think has DCIS and you operate on, and then comes back with invasive disease as a surprise. I understand that that doesn't really happen that often. But, if that invasive disease is something that's maybe not ER positive or, is a more aggressive tumor, then, that's not good, right? So, I think it's not just who has high risk DCIS, but who's hiding invasive disease in there. And, the breast group is really, aggressive about sampling when we do the core biopsies, but, we've all seen it. I don't think it's very frequent. But you could have, a surprising HER2 positive something that's not really going to be impacted by the endocrine therapy if they take it.
Right. Yeah, and I think, more long-term data from this trial will help look at some of those questions. Upgrade rates are anywhere from 15 to 25%, really realistically, depending on what you look at. And thoughts with these low grade to intermediate grade DCIS patients, the upgrade rate may be even lower. So.
Really great job, Megan. I guess I would only add that seems like such a selected population that would agree to enroll on this, and such a high uptake that are, as you've accurately pointed out, so different from probably the vast majority of patients that we see, that it's really hard for me to know what to do with this, because it just feels like it's a unique situation, which and very short follow-up.
Right. Yeah, totally agree. I mean, I think about 70% of our patients taking endocrine therapy and just active monitoring, when almost all the patients I feel like I see when they come into clinic are like, can you remove my cancer yesterday? So really unique patient population who would even enroll onto this. And then as we saw, half of the people randomized to surgery opted not to have surgery. So I would say definitely not representative of, I feel like, the patients that I see, although I'm a surgeon. So, take that for what it is. Okay, so axillary surgery, we talked about in SEMA and, a month ago. I'm not going to go too much into it in detail about the study design. I think we all kind of know who these patients are. T1 to T2 adult patients. Everything had to be less than 5 centimeters, clinically node negative with ultrasound and clinical exam. And they had to have planned breast conservation and postoperative radiation. They were randomized in a 1-to-4 randomization scheme, meaning many more patients who underwent sentinel lymph node biopsy. And they were looking for invasive disease-free survival, which was a compound endpoint looking at both contralateral breast cancers, ipsilateral breast cancers. Again, they were very specific about the types of radiation that could be used in this trial. Partial breast irradiation was not allowed, and they had to have negative ultrasound and clinical exam of the axilla, and they had to be T1 or T2, which was, again, different from sound, which was T1 alone. We've all seen this before and thought about it a lot. So median age 62, the majority were ductal, very, very low proportion of patients with grade 3 tumors. For the vast majority of patients, tumors were less than 2 centimeters. So 90% of patients were T1. And the T2 median tumor size was 2.5 centimeters. So we're not talking about many patients in this trial who had, 3, 4, 5 centimeter tumors in the T2 range. This is really small selected tumors. The vast majority HER2 negative, hormone receptor positive, almost no, essentially for all intents and purposes, essentially no HER2 positive and triple negative, even though they were allowed. So when we look, no axillary surgery, obviously we don't have any data on sentinel nodes. 85% of patients had no positive sentinel nodes. So again, historically, when we look at sort of all comers in the bigger trials, about 30% of patients would have positive nodes. So I think we are selecting a lower risk population here. Most patients who did have a positive node were 1 to 3 positive nodes, and a very small proportion of patients had 4 or more positive nodes in this group. In this trial, even though it was relatively more recent, the second phase of the trial, patients who had a positive node were actually randomized to an axillary dissection versus no axillary dissection. So among the patients who had an axillary dissection, 253 of them, most had N1 disease, and 13% ended up having N2 disease, which is very likely clinically meaningful. I will point out that, again, here, for the patients who had T2 versus T1 disease, the number of metastatic nodes was higher. So again, I think kind of thinking about as our group, as we decide who might be relevant for us thinking about omitting sentinel nodes, both Sound and Nsema, the T1 patients are much, much lower risk. The per protocol analysis, we already looked at these slides a month ago too, essentially no difference in their primary endpoint, which was invasive disease-free survival. Survival rate at 5 years was high, 92% in both groups. And I should say also this was a non-inferiority study. I'm sorry I didn't say that before. So you can see really no difference. When we look at overall survival, similar, no statistically significant difference in overall survival. When they looked at trying to find subgroups of patients who may, maybe would want to do sentinel node or not, they really also didn't find anything statistically significantly different between the two groups. So 5,500 patients omitting sentinel node and clinically node negative patients with early breast cancer did not have an inferior outcome to those who had a sentinel node biopsy. Survival was excellent at 5 years with or without sentinel node biopsy. And they sort of say de-escalation concept is suitable for patients who are 50 or older, grade 1 to 2 tumors, hormone receptor positive, HER2 negative subtype, and a preoperative tumor size up to 2 centimeters. So more or less the patients who we already think about for choosing wisely, considering omitting sentinel nodes for them. My take-home points from this study, I sort of was mentioning it to Hannah, I had a 33-year-old patient yesterday email me about Nsema, who has a small hormone receptor positive HER2 negative tumor, and asked me about my strategy on sentinel nodes. And I said, look, like you wouldn't have really been in this study probably. So mean age of 60, 1 centimeter tumors, essentially, almost all exclusively hormone receptor positive and HER2 negative. They had to have negative axillary imaging and exam to select out these very low risk patients. Chemotherapy was 2% higher in the sentinel lymph node biopsy group, likely reflective of the fact that we were finding more nodal disease in those patients. And then again, all of these patients received breast conservation plus whole breast radiation. And we had 2 patients in tumor board last week who were perfect candidates or decent candidates for omission of sentinel node biopsy. And Bentley and I were kind of debating because both of them are also great candidates for APBI. So I think we're going to see more of this. I think we have to be thoughtful about how we implement this in our practice, but I do think we're going to have to start thinking about these results. These are 5-year results. They're not 10-year results. But there are a lot of questions that we're going to need to think about here. Because a lot of the patients that we want to omit sentinel nodes for may also be really good candidates for APBI. So more to come.
Yeah, it's just, we all want to de-escalate logically. Again, the challenge is that, what if the imaging shows that it's a 1.5 centimeter tumor, but when you take it out, it's a 4 centimeter tumor. Then that's not the same patient, right? And so then presumably you've only done a lumpectomy. You could go back and do the sentinel node. That I think we're going to face awkward moments like that. And if you've done a mastectomy, it's not gettable.
Well, there were no mastectomy patients in these trials.
Right.
Right. So we can't, I don't think, I know we like to extrapolate data, but I don't think we can move this data into the mastectomy space right now because we're radiating. All these patients are getting radiation, right? So
and that's a key to their doing well. And so I think this is why this is a multidisciplinary conversation. And these I think it's really fascinating. But we were so privileged because we get such good imaging. Like what I just described did just happen to a patient I was caring for, but that's not usual.
Right. And I think, right. I will say I'm meeting with the tumor registrar next week so I can pull some of this data, at least to look at our patients who sort of fit the majority criteria so we can be a little bit more knowledgeable about how we think about these patients in our own practice. But I think the reality is that I have had questions from patients about both Comet and Insema, and we will continue to get them. So it's going to be something that we need to figure out how to address as a group in a multidisciplinary fashion, so that, you know, the surgeons aren't pressuring everyone else into not doing surgery, and have an agreement that if cases like you just mentioned, Hannah, where someone did get a lumpectomy and they upgraded, that we would be willing to go back and do a sentinel node, and not argue about that. So I think a lot to discuss as we move forward, but I do think, you know, we should be at the front end, not the back end of thinking about how to implement this in our own practice. People at this meeting were surprised that we hadn't. They were like, "Oh, well, what are you guys doing now?" I was like, no, "Nothing. This hasn't changed our practice at all." So,
Right. Ben,
so
what are you thinking?
Um, do we know when we started emitting sentinel node biopsies in early stage favorable patients here at Fred Hutch? Like, was it 3 years ago or last year?
you mean in terms of the over 70 population?
Yeah,
Yeah.
roughly.
I think our practice, my practice, I can speak to my own practice. I think my own practice changed probably within the last 3 to 4 years.
Uh-huh. Okay. Because I'm just thinking, so far I haven't seen any like nodal recurrences in APBI patients that we've treated, but it could just be that there hasn't been enough time passed yet. It does leave me wondering if there's a 15% chance that there was a sentinel node and we just treated the partial breast, are those patients guaranteed to have a recurrence? Or with the biology, if they're continuing 5 years of hormone therapy, is there a chance that that sort of resolves the lymph node? I don't know. Do you have any thoughts, uh, Dr. Linden or other med-oncs? Is like hormone therapy alone enough to sort of address an occult sentinel node?
No.
I would agree that would be very worrisome to leave macroscopic
Hmm.
disease just only for endocrine therapy. I mean, the hard
Yeah.
part here is that it's such a great idea to do this, but you really have to exactly follow the protocol. Because if we do APBI and we do no sentinel node, I feel like we're unintentionally leaving a lot of
Hmm.
risk on the table.
Yeah. This is a
Yeah.
really important thing for us to discuss.
Right. I think we're going to have to come up with some sort of algorithm and agreement that all teams can support. And, you know, as you guys all know, it is difficult for people to be adherent. And actually, that most people, if you ask them, they want the reverse Hughes treatment. They want the radiation and a lumpectomy and no endocrine therapy. That's their preference.
Well, and just to clarify, the CLGB 9343 had patients that didn't get sentinel node, right? Like they didn't all get it. So that's a little bit different. Or like there's at least a precedent. And it is important to like the sound trial, I think, did allow partial. It didn't have this like no partial breast allowed situation like in SEMA, but so there, you know, it may have been infrequent, but and so I don't think that we should rule it out. But yeah, tread cautiously.
I'm gonna, it's already 12:30, so I'm gonna, and Dr. Gillespie has good studies to talk about too. One thing that I wanted to bring up, we'll wait, we're all, anxiously awaiting the Alliance trial data, but one thing that I wanted to point out, which I actually in my mind was surprised about when I was looking at this, was the enrollment criteria for Alliance is N1 disease only, which makes sense. But this is going to be one of those scenarios where when this data comes out, if it shows that really that the axillary dissection is not, those patients don't have any benefit versus just radiation alone, we're going to have to keep that criteria in our minds, right? This is not patients with the internal mammary nodes. This is not patients with a superclav node. This is not patients with more node, multiple nodes or N2 disease, even just matted nodes. So for our own group to be thinking about making sure that when this data comes out, we really have a very specific idea of who these patients are. I'm not going to go through this. This was really just looking at who enrolled in the trial, and the kind of interesting parts of it were just I'm going to skip through all these, and that when we're trying to look at what were the factors significantly associated with patients who were randomized to the axillary dissection and had more nodes, and really probably of no surprise to any of us on multivariable analysis here, number of positive sentinel nodes, right? The YPT categories, if you had a lot of positive sentinel nodes, you're more likely to have more nodes positive on the axillary lymph node dissection. YPT categories, so if they did not have a complete response in the breast, and specifically those patients who have T3 lesions, more likely to have additional positive nodes. And then, of course, the number of additional nodes removed on axillary dissection. If you remove 4 nodes versus if you remove 16 nodes, you're more likely to have more positive nodes if you remove more nodes, period. This is something I think all of our medical oncologists would want to see, which is, the axillary dissection, 25% of patients had pathologic nodal upstaging. So while this may not make a difference current state for the majority of our patients potentially, there are always emerging therapies that are coming out for our patients, and something like upstaging from an N1 to an N2 or maybe an N2 to an N3 might be meaningful in terms of future systemic therapy options. So I'm gonna cut it out here so that Aaron can take over. Thanks, guys.
The one thing from that one, Megan, was the rate of additional nodes was less than MSK has reported from the retrospective data, quite a bit less. And whether that's just sort of selection criteria for the trial, but I thought that was interesting. Okay. I'll share my screen, and then
I think you would find the MSK attendings arguing that that's because they do really good axillary dissections.
Interesting. Okay, so this is also from the Washington State Medical Society meeting a couple weeks ago. So this, my part of local therapy is really, there's radiation and hormonal therapy in here. Happy to hear also input from the group, but I'll share. We'll do Europa real quick, and then a combined analysis from R2G 9804 and the ECOG 5194 trials looking at endocrine therapy benefit, and then the Supremo randomized trial of post-mastectomy radiation. So I won't belabor the reason for Europa, just looking at what is the best adjuvant therapy for older women with ER-positive breast cancer. It was a randomized trial. Again, T1N0, ER-positive, over 70. Specifically, they could have any type of radiation. Most did get partial breast, or they got hormonal therapy alone. It was radiation alone or hormonal therapy alone. What's this? And they had co-primary endpoints of IBTR at 5 years and this health-related quality of life, which is what I'm presenting here. Again, the radiation could be a number of things, although about 85% were the partial breast radiation, which is the 30 gray and 5 fractions typically. And these were the 2-year health-related quality of life outcome. And so this is from the QLQ-C30, using this global health scale, looking at the two treatment arms, baseline, showing that they basically separated by 3 months, where you had lower in the endocrine therapy arm than in the radiation arm. This was overall a mean difference of about 10 points on this scale. So this is kind of like the main finding around, using this global health scale. I will say these are fairly crude measures. So the fact that they did see this, is notable, like in terms of these more general quality of life indices. They were a bit surprised to see that radiation was as little as it was, even at 3 months post-treatment. But certainly the radiation was, may cause some shortly after the baseline within the first month. They then looked specifically, this is just showing the specific, but there's physical functioning, and the emotional functioning, cognitive functioning, social functioning, that were all slightly worse in the endocrine therapy arm. Looking at the specific symptoms, they noted differences in fatigue and insomnia, as well as some musculoskeletal pain related symptoms, which I think all make some sense. Although there was some question, like, were patients reporting more symptoms in the endocrine therapy arm? I do think that these are relatively consistent with what we know about those side effects. The main takeaway at 2 years is that, not a lot of recurrences are happening at all. I think that still need to follow up for longer regarding particularly distant Mets and other things, but certainly looking at IBTR and local regional recurrences at 5 years was the primary endpoint. So yeah, I mean, this is, we have 2 years of follow-up. We know a little bit about the quality of life between these two groups. The findings were, they're hypothesis generating. I think it provides a data point for when talking to patients, but it's a bit early to jump to any conclusions. Yeah, certainly, more options for patient-centered personalized care in the future, which is always makes things better and worse in some ways. So any immediate comments on that one, or do you want me to move on to the next? So I know we're a little short on time. Okay. I will then talk about the hormonal therapy in the good risk DCIS. So basically, to remind us, RTOG 9804 was a randomized trial of radiation or not for patients with grade 1 to 2 DCIS that was pretty small, versus the ECOG trial. It was actually a single arm observational study where cohort 1 was grade 3 and shows you this sort of 25% recurrence by 10 years. Which is why we pretty much treat grade 3 DCIS, but it was the grade 1 to 2 DCIS that had similar recurrence. Again, this was a single arm study. The main impetus was for this combined analysis was that there were variable uses of endocrine therapy between these two trials. So wanting to kind of look at how much was endocrine therapy. And although this analysis really focuses only on the patients that did not get radiation, rather than looking at any added benefit. Again, these are the two trials. The eligibility was remarkably the same. Both used tamoxifen as optional. And again, we're looking here at the radiation omission groups. So this is just showing you the combined groups. You had more people from the RTOG 9804, close to 60% that got hormonal therapy versus 30% from the ECOG trial. Certainly in real life, people often think it's closer to the 20 to 30% rate. These are just looking at the patient characteristics. I thought it's interesting that they also looked at negative by negative re-excision and then margin width, just because these trials did require 3 millimeters, even though our standard now is 2 millimeters. They also have grade 3 included because there was central review, and about 13% of patients were upgraded after central review. So that's why they were included in these studies and this analysis. So we learned a little bit about that. Big takeaway is that the in-breast recurrence rate was lower, 19% versus 11% with hormonal therapy use at 15 years. This was significantly reduced for invasive, but not DCIS. Which we'll talk about later. When they look at predictors of recurrence, really the margin width did not come out on its own, which is interesting, potentially helpful. But that size and grade are strongly associated. So I think we use those factors routinely. The subgroup analysis is really not that helpful. The one that draws your attention is that the largest margin width is the better with tamoxifen than without. So hard to know what to make of that. This, I think, is really interesting. The contralateral breast events was another sort of main outcome, and this was not significantly different. I talked to the woman, Jean Wright, who gave this presentation, and she was like, yeah, this was surprising. Not sure what to make of it, except that, maybe these are just really a sign of like low risk patients. And the hormonal therapy is, there's not enough events to see these differences. So conclusions really, this question of, I think we'll constantly, the data of, are we preventing invasive or DCIS? The data differs in different studies. Certainly this is showing the UK ANZ DCIS trial suggested that it was preventing DCIS and not invasive. And here we have invasive, not DCIS. Hard to know. We do know it's preventing some in breast recurrences. Certainly tumor size and grade are important. The margin width is probably less critical. We can follow our standard guidelines. And negative by negative re-excision is probably also acceptable. Controversial comment of the day. If endocrine therapy is not reducing the contralateral breast events, are we comfortable with radiation in these patients? I think that with PBI, we have been, anecdotally treating a number of patients, given, the 15-year rates are up to 15% without radiation. But, if we do radiation, certainly this doesn't necessarily answer whether we need hormonal therapy, but it's sort of an interesting, given the quality of life issues we know with endocrine therapy, is radiation a potential alternative? But I'll stop there. Any comments or questions before I move on to Supremo?
I think it's an interesting question, and a good one, Erin.
Always interesting to think about these things in the context of COMET, where we could also just do no surgery or radiation, although those patients were, again, getting some low dose of hormonal therapy, so complicates it. So I'll go to, and the other key finding or key comment from the authors themselves was that just a couple weeks ago, I believe she mentioned the NRG had proposed a trial in DCIS using molecular profiling to help the decision, and that was approved by the NCI. So that hopefully there's a new trial coming down the pipeline to further, help us risk stratify patients. So Supremo is probably the trial or the presentation that has created the most sort of question and uncertainty about, like, we also don't have the final publication like we do for Europa. Europa did a synchronous publication, which is always helpful. You get more information. So Supremo is basically a large randomized trial for patients that were either node N1 or N0. So they could be T3 N0 and they could be T2 N0 with grade 3 and or LVI. And they had about 25% of the patients that were N0. If they had positive nodes, they did have to go on to an axillary dissection. So that was, partly because when this trial was started, but that is an important thing to note. The primary endpoint of overall survival at 10 years, and then the list of secondary endpoints. Also important to note, so this was randomization of chest wall radiation or not, where it was required that they treat the chest wall, and radiation to the axilla was not allowed. That's maybe not the most critical part of this, but that the supraclav and the internal mammary node, so what we consider kind of the at least the axillary level, includes the axillary level 3 generally, and supraclav and IMN, that was really optional and per institutional standards. So that we don't really know yet anything about how many patients had really what we would call regional nodal radiation, which does limit this study a bit. So overall survival, certainly no differences here. They did, and that was the primary endpoint. They did look at local recurrence by node negative and node positive and showed a statistically significant difference in the node positive, but not the node negative group. And that was the same finding for regional recurrences. So at least giving us a little bit more information on, the patients that really may not benefit from this. And then the metastasis-free and disease-free survival, not interesting or not negative, basically. So the thing about this trial that, so the conclusions from the authors are pretty strong. And basically saying, no difference in overall survival, so no need for post-mastectomy radiation. I spoke with the Icro Miatini, who's the this is being recorded, but he's the author of Europa, and just about so obviously Ian Kunkler is the primary author. He also led the Prime 2 trial. So he's a clinical oncologist that does medical oncology and radiation oncology in Europe. And so his perspective is a little bit like Prime 2, which is to say, these patients don't need it. Now, so it's important to know which patients are included here, and what can we take away? Because I think that this is kind of the most aggressive perspective you can take. There are a couple things that I would consider that I think, in talking to a lot of other radiation oncologists, certainly, I think for the node negative patients, I agree, post-mastectomy radiation should be increasingly rare. I think we're already doing that. We pretty much don't treat T2N0, T3N0. We have an increasingly high threshold. I think this confirms that practice. The N1s, these patients all got axillary lymph node dissection. So in the current practice, if you have a sentinel node, we wouldn't necessarily do an axillary dissection in every patient. So it raises complicated questions of, well, should we do an axillary dissection or or, and if we do and it's negative, we could potentially then not do radiation. The dissection certainly comes with more lymphedema risk, although the radiation probably comes with more cosmetic reconstructive complications. So that may complicate things, but keep in mind that these data are really for patients that have had a full dissection. And then chest wall radiation alone should be increasingly rare. I think we also have taken that approach. There were other studies that enrolled and reported sort of in the meantime. This is just showing you, we learned about EORTC 22922 and MA20 after this trial was well open and even had probably finished enrolling. So the benefit of the regional nodal radiation as a component of post-mastectomy radiation may also be something to consider. So if you're going to treat patients, this may lead us to having a higher threshold to treat, certainly, but I think treating comprehensively is the safer way to go. And yeah, I think happy to hear comments or questions about that trial as well. Ben?
Yeah, for the chest wall alone radiation, I feel like sometimes we have a otherwise like pretty favorable looking, and we sort of try to apply Z11 and say, oh, maybe we can do like chest wall with high tangents. Um, I may have missed some of the slides earlier, really digging into that, but what are your thoughts about that, Erin? Instead of doing comprehensive regional nodal. Yeah.
Well, we don't know yet what people actually treated, but this trial, if it was, other trials have shown a potential benefit to regional nodal radiation. This one showed a very small local and regional reduction. So I just think that if you're going to treat the chest wall, you're causing most of the side effects cosmetically, and you're even treating the pec muscle, so you may be contributing to shoulder dysfunction, and you're not getting the potential big, if there's benefit, it's very well could be from the nodal treatment. So that's like, we used to say the IMNs were like this sort of like place, that we don't screen these, we don't find them, and that may be harboring, disease that goes systemically. Like whether or not that's true, it's hard to know, but I just think that you have to think hard about doing chest wall only radiation after this trial, particularly if they've had a dissection.
Yeah, those are good points. Thanks.
We have 4 minutes to spare. If anybody has any final thoughts, or we can convene early.
Well, I did a deep dive on the what happens if we omit treatment of axilla totally from the CalGB. And it doesn't show how many of those patients actually got any axillary surgery, but there was a 10% local regional recurrence rate in patients that omitted at 10 years. And of those 10%, 6 out of 32 patients, so like 20% were regional recurrences. So if you do the math, then I guess if you emit radiation and maybe you did, maybe you didn't do any sentinel node biopsy, there's a 2% risk of regional recurrence in that study population at 10 years. Was my conclusion. Thought that might be helpful or interesting. And I guess when comparing that to the Nsema trial, there's the age difference, median age being 60 versus age being 70 and older. So I think the overall the CalGB is still pretty encouraging, where for these old patients where we omit sentinel node, maybe it is more reasonable to still consider just APBI. but for younger patients with no sentinel node, maybe we should really still do tangents or whole breast radiation. That could be one way we interpret that data.
Yeah,
Thanks, Ben. I
definitely think
appreciate that.
yeah.
I think the age factors in heavily in terms of thinking about future risk and trying to err on the side of not omitting too much in the younger patients. Definitely keeps our multidisciplinary team in business because this has gotten, it feels like it's gotten even more complicated over the last 10 years in terms of how we manage just even the simple things that used to be lumpectomy, radiation, and sentinel node, and now it's much more nuanced. So thank you guys so much for presenting. Really helpful, and I think a lot of data that needs to mature and that'll be more helpful when we have a little bit longer follow-up as well.
Yeah, awesome. Thanks for your interest.
Thanks, everyone. Have a good day.
See ya.